Good evening and welcome to tonight's Men's Health webinar with Dr. Itai Goldenberg. Tonight, Dr. Goldenberg will discuss the signs, symptoms, and treatment options for erectile dysfunction and stress urinary incontinence. During the presentation, you were free to ask your questions using the chat box at the bottom of the Zoom screen. So you can ask confidential questions right in that chat feature that Dr. Goldenberg will answer after the first part of the presentation and then again at the end. So we will cover erectile dysfunction and stress urinary incontinence and have two opportunities to have your questions answered. Without further delay, I'd like to welcome Dr. Itai Goldenberg.
All right, Mike, thanks for the introduction. Welcome everyone who's logged in. Appreciate you taking the time to listen to me talk about these important issues in men's health. I hope everyone can hear me. I'm used to doing these types of presentations in person to an audience, and I will admit, a year into this, I'm still getting used to doing this over the web. But thank you all for attending, and I hope this is a nice informational session for you. Let's get started here. Here's a picture of me. My name is Itai Goldenberg. We're 6 APPs. I joined here 8 years ago, and before that, I did my residency training at WashU, and then afterwards I went to New York and did a fellowship specializing in men's health, really focusing on male fertility issues, sexual dysfunction, and urinary incontinence, all really focusing on men's health. So today I'd like to focus on two things. The first part I'll talk about is male stress incontinence, and the second part we'll be talking about male sexual dysfunction. I'll take questions after each part. Like Mike said, please put anything in the chat. Mike, send me a message if there's any difficulty hearing me. I just got a message saying the internet's unstable, so if there's an issue, just text me or send me a message if you can't hear me well. All right, so I'm going to start talking here about male stress incontinence. Maybe to take a step back, what is continence and incontinence? So not pictured here on the screen up high are the kidneys. The kidneys make your urine, and then the urine comes and fills the bladder. The bladder is a muscle that when it squeezes, it pushes the urine out through the urethra, which is this tube here. Oops. To stop a man from always leaking, there's really 2 points that are preventing leakage at all times. One is inside the prostate, there is musculature, and then beyond the level of the prostate, there's this sphincter muscle that always stays closed until a man chooses to urinate, and that muscle opens, allowing the urine to flow. So what is stress incontinence? So there really are 3 types of incontinence. One is stress incontinence, meaning that when you have a stress or an abdominal pressure that pushes on the bladder, and then the urine involuntarily leaks, usually through coughing, sneezing, heavy lifting, increases the abdominal pressure, and then the urine gets pushed out beyond those 2 safeguards inside the prostate and that external sphincter. If a man is missing the prostate or has issues with those muscles, that's when this usually happens. There's 2 other types of incontinence, either what's called overactivity or an overactive bladder, and urge incontinence, where the bladder becomes unstable and pushes too hard, and then the urine is then pushed through that musculature and through the prostate by like involuntary contraction. And then some men have a mixture of both stress and urge incontinence. How common is it for a man to have stress incontinence? It's about 1 out of every 20 men. It's most commonly associated with prostate cancer surgery. What happens is when a man has prostate cancer surgery or any other prostate surgery, the musculature inside the prostate can be injured, especially when the prostate's removed. When the prostate's removed, you're relying really only on that sphincter muscle that's beyond where the prostate used to be. Most men do have urinary incontinence after they have their prostate removed and start to regain their control as time goes on after the prostatectomy. Other things that can be related, or especially if you had your prostate removed and have other issues, including neurologic disorders, radiation therapy, or pelvic trauma. Studies have shown that having urinary leakage, incontinence for any reason, especially stress incontinence, can cause many issues with a man's quality of life. As I mentioned, when a man has prostate cancer and has their prostate removed, the prostate is cut out. When the prostate's removed, it's removed here from the base of the bladder, and then here on the other end where the urethral sphincter is. To do so, where the nerves are usually pulled off the prostate. We'll talk more about those nerves later. And then you're left with this opening here, which is then sewn back together. The external sphincter, which is right here, is really the only part now that you have to protect you from leaking when coughing, sneezing, lifting, and having heavy activity. So what can be done when a man has stress incontinence? Well, to start with, like I mentioned, right after the prostate's removed, most men do have leakage. And with time, that does improve. Ways to help that improve is strengthening those pelvic floor muscles. That can usually be done by doing Kegel exercises, working with pelvic floor physical therapy, or some biofeedback exercises. Also doing behavioral modifications, which include staying away from foods and drinks that can really cause your bladder to be more overactive, like caffeinated beverages or carbonated beverages, reducing your fluid intake, and also going to the restroom before you go and do an activity that you think is going to increase the amount of stress to your bladder. You know, like going to doing sports, emptying your bladder beforehand, you have less risk of leaking with a stress incontinence. Other things like coping things, pads and diapers and catheters are all ways that you can manage incontinence. And when a man has leakage after their prostatectomy or other surgeries, I usually try to characterize how many pads or diapers a man wears in a day to figure out if the man has mild, moderate, or severe stress incontinence. These coping solutions do have a cost with them. I think I sometimes forget to ask men, if they're leaking, that it can be very expensive to have so much leakage and need to have protective undergarments or what have you in order to protect from leakage. So normally I'll talk to men that have their prostate removed in the short term. Most men that have their prostate removed for prostate cancer will see me in the 3 to 6 month window after their surgery to discuss their leakage. But if man still has leakage at that window, we usually really reinforce the stress incontinence pelvic floor muscle exercises, using these Kegel exercises, going to see a pelvic floor physical therapist to help strengthen the musculature. If those things really don't help enough, and it's been about a year or so after the prostate's been removed, I like to discuss these long-term solutions to stress incontinence. The two things I really want to focus on most in terms of these long-term solutions for stress incontinence are a male sling and an artificial urinary sphincter. I'll talk first about the male sling. This is the Advance XP system. This is what's called the trans-obturator sling. What happens, we put a piece of mesh through the pelvic bones and under the urethra in order to elevate the urethra and put it in a better position, allowing the muscle that's left behind after the prostatectomy, that sphincter muscle, giving it some extra support. This is a really great operation for guys with mild to moderate incontinence, which I usually characterize as 3 to 4 pads per day. These are men that usually have some control of their urine. They just need extra bulk and extra support to allow that muscle to work better. This device works on its own. It's placed in usually an outpatient setting where most men have a catheter overnight, and that's removed in my office the next day. Over 90% of guys are happy they have a procedure like this. The way it works, like I mentioned, is that the sling acts as a hammock and repositions the urethra in a better area to allow for control with coughing, sneezing, and heavy activity. The other option is something called an artificial urinary sphincter. So an artificial urinary sphincter is a device that works in three parts. There is a cuff that sits around the urethra here. This is in the position similar to where the sphincter muscle that I talked about before is normally in place. This is best for men that have severe, moderate to severe incontinence, or men that have previously tried a sling or other options and hasn't worked for them. Additionally, men that have had their prostate removed and had radiation therapy tend to do better with an artificial sphincter versus a sling. You put this cuff here and it replaces what you had before, which is that circular musculature around the urethra. Now this cuff stays closed all the time. When you want to urinate, you squeeze this control pump that shifts fluid out of this cuff, allowing an open track and allowing the man to urinate. And then over the course of about 2 minutes or so, the fluid comes back from this reservoir through the system and closes the cuff back up in order to allow you to stay dry at all times from the time you push the device until afterwards. Like I said, this is the gold standard of treatment. It really does allow for significant improvement of the quality of life. Really great for guys with moderate to severe incontinence. I'll say my patients that I've done artificial sphincters on in my practice are probably hands down my happiest patients in my practice, guys that were leaking 5, 6 diapers in a day and were able to get them to 1 pad or less in a day are overjoyed with their success. I do have a video here, which I think is helpful to understand the way this device works. So if you look here, this is the artificial sphincter control button that sits here. Inside deep is this cuff. When you squeeze the pump, the fluid then leaves here, allowing your urine to flow. And then over the course of the next 2 to 3 minutes, the cuff then closes back up, allowing pressure along the urethra at all times afterwards. Artificial sphincter is a surgery where it says outpatient. I usually keep my patients in the hospital overnight in what we consider an outpatient in a bed or a 23-hour admission. Small incisions, usually one small incision under the scrotum and one small incision on the abdomen. You really have to take it easier for a couple weeks after the surgery. The device is off after we put it on. It's in the open position at all times. And then we turn the device on, usually about 6 weeks after surgery, once the urethra is completely healed. Satisfaction rate's very high, well over 90%. Well over 90% of guys would recommend that this surgery be done again for themselves or to a family member in a similar situation. Artificial sphincters and male slings are usually both covered by insurance. This is one of the things that we would verify before you were scheduled for a procedure like this. So what we would do is if you were a candidate and would like to proceed with either a male sling or an artificial sphincter, we would do a workup in the office, which usually includes a cystoscopy where we look in with a camera to look at the muscle that's left behind to see how much muscle is there, make sure there's no other anatomic abnormalities. We will usually do some other tests to look at the function of the bladder, either a flow study or a urodynamic study. And based on that information and how much you're bothered by the urinary leakage and how many pads you wear in a day, decide together which operation is best for you. And then from there, we can submit that to your insurance company and can usually get coverage. Men with artificial sphincters, like I said, really tend to be very happy with the device. Once it's installed and functional, men would say they would definitely do this type of procedure again. Like any procedure, though, there is risk. With both a male sling and an artificial sphincter. Anytime I put any type of implantable device inside someone's body, I think the biggest risk that I'm concerned of and that my patients are concerned about is infection. We do give antibiotics before, during, and after the surgery in order to reduce the risk of infection, but that does not make the risk of the infection zero, but makes it very low single digits. Additionally, with the male sling, it's possible we put the device in and it's either too tight, causing you not to be able to urinate well or having a weak urinary stream, or too loose and having you still have leakage. With the artificial sphincter, same risk. If we put the cuff inside, there's different sizes to the cuff. We really are very careful about measuring and trying to get the perfect sizing that allows you not to leak, but also not to be too tight that you have difficulty urinating. Sometimes an artificial sphincter, because of all the mechanics, can break down. The average device usually lasts about 10 years or so, and at that point would usually need to be replaced. Like any other surgeries, they are done under general anesthesia, so there is a risk of the anesthetic or risk to any type of the surrounding structures nearby. Overall, for men that have had prostate cancer and had their prostate removed, or had other either pelvic trauma, had a TURP procedure and had injury to their prostate, or other reasons that they have stress incontinence and continue to have this for about a year or so after their surgery and have had difficulty controlling their stress incontinence after doing pelvic floor exercises and pelvic floor physical therapy, there really are other options, which I think most men would say can really help them out with this artificial sphincter or urethral sling. They're all placed inside the body, have high patient satisfaction, and can really restore normalcy to a man's life. There's definitely more information at fixincontinence.com if you have more questions about this or want to hear from patient testimonials. But I think I was going to take a minute now to answer any questions you have about stress incontinence. Okay, so with that said, if there's not any more questions, I'm going to move on to talking about erectile dysfunction and sexual function in men. I think, as long as these slides will work. Oh, there we go. Okay, so erectile function or erectile dysfunction is the inability of a man to achieve or maintain an erection firm enough for sexual function. So when I think of, male function and getting an erection, if you think about the anatomy of the penis, I think of it as really 3 tubes. There's the 2 tubes that are here represented in red. These are the erectile bodies. The erectile bodies are what fill with blood when you want an erection. So at the flaccid or relaxed state, these tubes look like this. There's one major artery that runs through each of the 2 corporal bodies that sit side by side on top. And when the blood flows into the penis, it fills with blood. And then there's a sheath around here that constricts and allows the blood to stay in the penis to maintain a firm erection. The urethra that we talked about mostly in the incontinence and urinary process is the tube that sits underneath here that allows for urination. When a man wants to get an erection, I usually think of it as a multi-part process. I think first it starts in your head. You need to be in the right situation, in a low stress environment, and being stimulated. Once that signal leaves your brain to go down to the penis, you have to have normal blood vessels, normal nerves that then send that signal down to the penis and allow the process that I just talked about blood filling the penis to happen. It's really common for men to have problems with erections. About 1 in 5 Americans over the age of 20 have erectile dysfunction. And the number that gets me is more than half of men over the age of 40 have some degree of erectile dysfunction. Very, very, very common. Affecting about 40 million American men. As I mentioned before, when I think about the penile anatomy, in order to get an erection, you have these 2 cylinders here, these erectile bodies, and underneath is the urethra that you urinate through. These are the 2 arteries, one in each of these corporal bodies that then fill with blood, filling all these sinuses full of blood and then constricted by the sheath, which allows you to have a firm erect penis. What are the most common reasons why men will have erectile dysfunction? Like I mentioned, the act of getting an erection is your penis filling with blood. Therefore, vascular issues, men with vascular or blood flow issues are the most common to have erection problems. Also men with diabetes. Diabetes often can affect the nerves that transmit the signal down to the penis, as well as the blood vessels themselves. Medications often can affect the way the blood vessels work and cause erectile dysfunction. And pelvic trauma, prostate cancer surgery, and neurologic problems often do cause erection problems as well. So I want to focus a little bit about each one of those things that I had mentioned before. Starting off with diabetes. Diabetes is really common. Over 15 million American men have diabetes. And the data would show that men with diabetes often don't respond as well to the most common treatments that we have for erectile dysfunction, like pills. Often men with erectile dysfunction and diabetes have more severe erectile dysfunction and have a worsening quality of life because of their erectile dysfunction. So ED pills often, which I'll talk about a little more in detail, often don't work as well on men that are diabetic and have erectile dysfunction, because the diabetes itself not only affects the blood vessels that are important for getting a good erection. Additionally, it can affect the nerves that send that signal from your brain down to your penis to say that they want to have an erection. Things that can increase the risk in diabetic men of having worsened erections include being older, years of having diabetes, and I think most importantly, poor glycemic control, meaning you're not controlling your diabetes so well. The higher your sugars, the higher risk of getting injury from that high amount of sugar in your bloodstream. And then heart disease. And erectile dysfunction and heart disease are, really do work similarly in a very similar process. Often men with erectile dysfunction end up developing heart disease within 2 to 3 years after that they developed erectile dysfunction. And if you think about what's going on in terms of getting an erection, the important artery I talked about to get an erection, this penile artery, is about 1 to 2 millimeters in size. There's the two arteries inside the penis that deliver the blood flow. If you compare that to the other important arteries in the body, especially the coronary arteries, the blood vessels inside the heart, that if they're clogged up or don't function as well, can cause a heart attack. Those are 3 to 4 millimeters in size, significantly larger. And the carotid artery, the artery in the neck, that if it's blocked can lead to a stroke, is even larger than that. So often men will develop erectile dysfunction before they develop some of the other things that are important for blood flow, like heart disease or stroke. How do you reduce your risk of erectile dysfunction, especially for men with heart disease? Exercise, eating well, not smoking is a really important risk factor that can help reduce erectile dysfunction risk. Losing weight, reducing your stress. I'll take a minute here to talk about testosterone. So testosterone is the hormone that's made by a man's testicles. Testicles really have two important jobs. One is to make sperm, and the other is to make the hormone of testosterone. Testosterone that gets into your bloodstream and helps a man with energy, desire, and mood. As men age, oftentimes they don't make testosterone as well as they did before. Approximately 4 in 10 men over the age of 45 may have a low testosterone. It's often common to see low testosterone in men that either are overweight or have diabetes or have high blood pressure or high cholesterol, all other risk factors for erectile dysfunction. So often men will come in with a low testosterone and other reasons for erectile dysfunction. And we need to kind of figure out what's going on and what's the major cause. When a man has low testosterone, there are multiple things that we can try. One, we check a blood test to check the testosterone level. If it's low, we recommend a second blood test to confirm that low finding. But with the man has two low testosterone blood test readings, there are multiple medicines now that can be given. Some are off-label medications that can be given to stimulate your brain to send a stronger signal down to your testicles, or we can give a man testosterone. Instead of having them make it on their own from their testicles, they can get testosterone either through a gel or a patch or an injection or an oral medicine pill that can be taken twice a day in order to give you testosterone. Going back to testosterone, there is some literature to also say that men that have a low testosterone and then are taking certain medicines for erectile dysfunction, like pills to help with ED, if that same man has a normal level of testosterone, they will get a better response to those pills and erectile dysfunction treatments. So I do think checking a man's testosterone, and if their testosterone is low and they are bothersome erectile dysfunction, it's reasonable to give them a trial to raise the testosterone to see if some options that weren't working before may work better with a normalization of the testosterone levels. Erectile dysfunction and prostate cancer. I think you've seen this picture before. This is a diagram of what prostate removal looks like. When the prostate that sits right here during a prostatectomy, it's removed from the bladder side and the urethral side and then removed. The nerves that run here that are important for erections are peeled off the prostate, and it's nerve-sparing prostatectomy. You can see here these nerves are left in place, and then everything's sewn back together. Initially, after the prostate is removed, many men do have difficulty with getting erections because of just the sheer movement of those nerves off of the prostate, which may cause trauma to them. Many men with time improve their erections. However, about 50% of men that had prostate cancer surgery don't regain their erections to how they used to be. In addition, the other common treatment for erectile dysfunction is radiation therapy that's often done from outside the body at that area where the prostate is, and those nerves can be damaged with radiation therapy. Approximately 50% of men that have radiation therapy do get worsening erectile function. Additionally, some men have to have their prostate removed and in addition get radiation therapy, and those men have 2 hits to those nerves and to the blood supply nearby that can then cause worsening erectile function. And then I want to talk a minute about Peyronie's disease. So Peyronie's disease is a fibrous plaque or scar tissue inside that sheath that contains the blood vessels that allow for erections. What happens is, like I mentioned before, when that sheath is filled with blood, it gives an erection. Now, when this fibrous sheath, this fibrous plaque is there, usually because of some small incidental trauma and overhealing of that area, you can develop a plaque. That plaque doesn't stretch as well as the rest of the penis. And so when you get an erection, you can get curvature in the direction of where this plaque is. Sometimes it can also cause penile shortening because of that plaque being there. There are multiple treatment options for Peyronie's disease, and those include conservative therapies like stretching of the penis or wearing something called a traction device, something that can stretch that plaque out. There is one FDA-approved medicine to allow for breakage of that plaque called Xiaflex that can be injected into that plaque to help it break down. Or surgeries can be done for Peyronie's disease, including what's called a plication procedure, where we shorten the opposite side of the plaque in order to straighten the penis, grafting, where we cut the plaque and then sew in a patch graft, or if a man has erectile dysfunction and Peyronie's disease, we'll often offer a penile implant. So that's kind of my overview of kind of the problems, medical issues that can often lead a man to have erectile dysfunction. And so my next part is going to talk about what are the treatment options for a man that has erectile dysfunction and what can be done. There's lots of things out there, and I definitely want to touch a little bit on each of them. There's not one answer, I think, that's right for each patient or their, for them and their partner. And so I'll try to touch on the high points on all these. Well, these are all things that I think if you're interested in having treatment for erectile dysfunction, I think knowing what's out there is the first step, and then talking with your practitioner about, which is the best option for you and for your partner. So I'll talk a little bit about pills, injections, vacuum device, urethral suppositories, and a penile implant. Before I get into that, I also maybe a quick mention about the other therapies that are out there, PRP injections, stem cell therapies, and shockwave therapy. All these are considered investigational at this time by the American Urology Association. I think the best literature really right now talks about shockwave therapy that has been shown to help blood vessels grow inside the penis. This is right now an off-label therapy that has been shown to have some benefit, especially for guys with mild to moderate erectile dysfunction, allowing new blood vessels to develop. Oral medicine or pills. So these are the most common first-line therapy for men with erectile dysfunction is pills like Viagra, Cialis, Levitra, multiple medications that have been on the market for a long time now. I will admit a lot of men start by getting these medicines from their primary care doctors even before they come and see a urologist, as I think many primary cares have been comfortable and happy to give these medicines due to their high efficacy for many men. How do they work? So PDE5 inhibitors, when they're taken and they get into the bloodstream, depending on which medicine you take, usually an hour or so before sexual activity for most pills. Some pills do last in your system for up to 36 hours. They allow the blood vessels in the penis to be more amenable to stimulation, meaning if you take those pills, and they're in your bloodstream, you'll have a better erection than you would have without them in your body. About 60 to 80% of men do have improvement of their erections with pills. There are some potential side effects, including headaches, flushing, or an upset stomach. There are certain medicines you can't take together with these, including nitroglycerin or nitrates. Many men do have a benefit from them, but there are also many men that have benefit from pills for a number of years, and as time goes on, do have decreased success with them. The next thing I'll talk about is a vacuum erection device. A vacuum device is a cylinder that goes over the penis, forming a vacuum or a negative pressure space by either pushing a button that's battery operated or squeezing a pump that pulls the air out of that tube, and therefore the blood then is pulled into the penis. Once the penis is full with blood, a ring is placed on the base of the penis in order to maintain the erection. Satisfaction rate kind of varies based on, I think, who you ask with this. This says 60 to 80%. I'll admit in my patient population, it is a bit lower. It's not because the device doesn't work. It's that in order to maintain a solid erection, you need to put this ring on the base of the penis. And many men do complain of numbing or discomfort and uncomfortableness from having that ring on the base of the penis. I definitely do recommend that many men, after they have prostate surgery and have their prostate removed, get a vacuum device. I found that in order to prevent loss of penile length after a prostatectomy, many men can use the vacuum device in order to stretch the penis and reduce penile shortening or penile curvature like Peyronie's disease by using a vacuum device once or twice a day during their healing process. Urethral suppository. So this is a very uncommonly used medicine at this point, but the way it works, it's a medicine that's refrigerated. It is in an applicator like this and depositing a small pellet into the urethra and then removed. That pellet is then absorbed and picked up by the corporal bodies here, allowing dilation of the blood vessels inside the penis. The upside of this is that there's no needles or anything. It's deposited into the urethra. The downside, the medicine needs to be refrigerated, and that because it's a little bit non-specific, it's absorbed from the urethra into the penis. It's also absorbed by some of the surrounding blood vessels and sometimes can cause dilation of those blood vessels, which can cause lightheadedness or dizziness. So the first time I have a man try this, I have them do it in my office. We check their blood pressure, make sure it works well for them. And I do have some patients that are very happy with it. But there's a high level of dropout with those. Intracavernosal injection therapy or penile injections, I think look really scary when you haven't seen this before and watch this on these slides. But I will admit my patients tend to be very happy with these, especially if they're trained well on how to do the injections. The way it works is it's a tiny needle, usually an insulin needle, that's injected into the penis itself. You're injecting a vasoactive medicine, so a medicine that causes the blood vessels to dilate. When those blood vessels are dilated, it allows blood to flow in and hopefully allow for sexual activity, usually 5 to 10 minutes after the injection of the medication. I do have many patients that are happy with these injections. The upside is once you're comfortable using it, many men use the same dose for multiple years. The downside, it is an injection into the penis, which I think can be something that you need to get comfortable doing, especially if you have a dislike or a fear of needles. Additionally, there is a small risk of bleeding with using the shot. And the biggest risk I worry about is because it's very potent, there is a risk of a prolonged erection that lasts for more than 4 hours. That can be an emergency. So the first time a man tries these injections, I actually teach them how to do it in the office to make sure that they're comfortable, that they can do it well, and that they don't either have too poor or too good of a response, and they're comfortable doing the injections at home. And then finally, I want to talk about a penile implant. So a penile implant, there are multiple models, and I will talk about those in more detail in a moment. But the way an implant works is those blood vessels that you see here inside these two corporal bodies are replaced with cylinders. Those cylinders are placed inside the corporal body, surrounded by the man's natural sheath. And the most common implant is a 3-piece implant where there's 2 cylinders inside the corporal bodies, a pump that sits inside the scrotum, and a reservoir of fluid that sits down in the pelvic area or in the abdomen. Very highly satisfactory. The way this works is when you want to have an erection, you squeeze the pump, and then fluid is shifted from the reservoir into the cylinders. And when you're done having an erection, you press this release button, and then the erection goes down. Most common side effects, it is a surgery, so there is risk, like any surgery, of discomfort, bleeding, or injury to surrounding structures. Because it's a device placed inside the body, there is a risk of infection. The most common implants we place are coated antibiotics in order to reduce that risk of infection, really keeping it to about a 1 to 2% risk of infection. And satisfaction rate is very high. There are different types of implants. Like I mentioned, the most common placed implant is a 3-piece device with the cylinders, the pump, and a reservoir of fluid. An implant I think that is also a very nice option for men is a 2-piece device, which has the cylinders that are placed inside the corporal body and a pump here in the scrotum without a reservoir. This device usually stays about 60 to 70% inflated at all times, and by pumping the pump, you get the rest of the erection. And something called a malleable implant, which are these semi-rigid rods that you can bend down and bend up, bending up when you want to have intercourse and bend down when you are in the resting state. The rods always stay firm. The most common implant, the 3-piece device, the AMS 700, comes coated in antibiotics, has built-in antibiotic protection. The advent of these coated devices is really what's significantly reduced the infection rate with devices and has really allowed more men to get these implants due to the significant decrease in infections after these procedures. How it works. So I do want to show a quick video here, I think may help explain what I just talked about. This is that AMS 700. You see the pump that sits in the scrotum. When you squeeze it, you're shifting the fluid from the reservoir. It then shifts through the system into the cylinders, allowing for an erection to occur. You can then leave the erection for as long as you want, and then you press a release button, and then the fluid then shifts back into the reservoir here in the pelvic area. until you until you want to have an erection again. Sorry. All right. And this is a patient with their implant in place. You see at the resting state, really nothing is visible. Everything is inside the body. When you want an erection, you squeeze that pump here inside the scrotum, shifting the fluid into the cylinders in the penis. As you see here, the device is inflated, it's a firm erection, and it looks very natural. And like I said, all the tubing and everything is concealed. And when you want your erection to go away, you can pull that pump up to the skin. I don't know if you can see the outline of the pump here in the scrotum, and then you press the release button that shifts the fluid out of the penis into the reservoir that's up here. In order to get every little bit of fluid out, you can squeeze the penis in order to get all the fluid out to allow for a completely detumesced penis. What to expect with the penile implant surgery. This surgery is either done as an outpatient. I do have plenty of patients that have the procedure and go home the same day. Usually I leave a catheter in them overnight, which they take out themselves at home. Some men, either because of other medical conditions or their preference, decide to stay overnight for the surgery, which is also fine. We give antibiotics before, during, and after the surgery. Usually 1 or 2 small incisions on the scrotum or on the abdomen. And then most men do say they're pretty sore for about 7 to 10 days after the procedure. I recommend staying with only light activity for about 2 to 3 weeks after the surgery. At 2 to 3 weeks, you can return to most activities, but no sexual activity until you're completely healed about 6 weeks after surgery. Insurance oftentimes will cover a penile implant. This is one of these things that what we do is we're really careful to make sure that we submit to the insurance companies. Boston Scientific, the manufacturer, will help us to make sure that we cross our T's and dot our I's and make sure that there is financial coverage. And that you're eligible for payment. There are some financial assistance options through Boston Scientific as well. Patients have been very happy. Like I said, satisfaction rate for patients and for their partners is well over 90%. I'm gonna fast forward in a second to talk to Cliff, who we're lucky to have here, and him and his wife Marilyn, who's normally will be here, wasn't available today. We'll talk about their journey with a penile implant. And like I mentioned, very high satisfaction rate with patients as well as for their partners. It is typically covered by insurance and often an affordable option and long lasting. The average device usually lasts about 10 to 15 years and giving a natural appearance, and of all the options really does mimic the natural function of spontaneity and all concealed inside the body. I think I mentioned most of these things. As a surgical procedure, a penile implant does have risks, including pain, infection, erosion or injury, or dissatisfaction with the device. I would say the satisfaction rate is very high, but is not 100%. And I really try to make sure that any man going into a surgery like this knows the pros and cons and the risks and the benefits. There's definitely much more information, and I could keep talking about this for an hour, but I'm going to give the floor up to Cliff and have him answer your questions, and I'll answer questions at the end. There's additional information at edsecure.org. And then I'm going to turn over to Cliff. Is that him? Did I hear you? Cliff and Marilyn?
We're getting them on here.
Oh, perfect. All right. Well, thank you all for your attention. I'll let Cliff speak, and then I will tune in for more questions at the end. Thank you all for your time and for your attention.
Well, good evening. My name is Cliff Pollock. Unfortunately, my wife couldn't be with us this morning, or this evening rather. And basically what you're going to hear is the journey that I went through with my wife from the time I was diagnosed with prostate cancer through getting the penile implant. I will say one thing, that ED really is a couples issue. It's not just a male issue. It affects couples. And if anybody has if there are any ladies in the audience that has any questions about it, later on, we will post the phone number that you can use to call my wife if the ladies have any questions, and she'd be more than happy to talk with you. As far as what happened with me is when I was 58 years old, I was diagnosed with prostate cancer. Like most people, I went in for my prostate exams every year, and I had basically a 3.1 PSA for many, many years. And then all of a sudden it shot up to 6.3, had a biopsy, it was totally negative. 6 months later, had another biopsy, it was 10.4. At that point, they did a second biopsy, and only one of the 12 little spots that they biopsied was positive for cancer. Being the kind of person I was, the doctor said, you know, this is a very slow growing cancer. You've got a lot of time to make your mind up about what you want to do, radiation therapy, pellets, all kinds of things. I was of the impression that if there's something in me that can grow and spread, I want it taken out. So I had my prostate taken out at 58 years old. After that, went back to the doctor and basically asked, I could get no erections, and they put me on Viagra. I will tell you, the Viagra gave me major, major headaches to the point where I just did not feel like having sex at all. So they switched me to Cialis and Levitra, and in the basically year that I took all three drugs, never had one erection, even though I was taking it correctly, you know, not with food, but after food and everything. So I went back to the doctor, and the urologist told me, he said, okay, we're going to use a vacuum device, an external vacuum device. And in reality, it worked fine. Unfortunately, that vacuum device is not very spontaneous. And like Dr. Goldenberg said, you have to pump it up and then put a band, which I call a tourniquet, on the base of the penis. When you do that, a couple things happen. Number one, the penis gets cold. Number two, it gets blue. And number three, when your spouse looks at it, it just doesn't look normal. It worked for a little while. My biggest problem with it was the fact that when you have to take off the restriction band, it hurts going over the head of the penis. So I decided to stop using it. At which point, the person I was going to had no other options for me. And for 2 years, I basically was in limbo, totally lost my manhood, could not have erections, did not have any intimacy with my wife. And luckily, I got a letter basically to invite me to a seminar, which is kind of like this, which talked about some of the other options that were available. And after speaking to the physician and hearing what he had to say, my wife and I went home, and we decided that the implant was, for us, the answer. So the day after my 60th birthday, I had the implant done. That is the second best thing I did in my life. The first one was marrying my wife 53 years ago. My implant lasted 14 years, and after 14 years, it ended up, it finally failed, and I had a replacement done. I am now 75. I have a brand new implant. My life is still the way it was before. We're very intimate. It's very nice to have an implant for a couple of reasons. Number one, when you travel, you don't have to have anything on ice. It's in you. It's wherever you go, you are ready to have intercourse. The other thing that's very interesting is that, you know, if you have an implant, you don't have to worry about this 4-hour issue. Not that you're going to leave it up for more than 4 hours, but the reality is you could if you wanted to. Some of the things people ask me is, number one, how was the recovery? My recovery for both implants was very uneventful. They did give me medical pills to take when I went home for pain. I ended up just taking Advils, and that took the edge off everything. So I never took the medication they gave me. After 2 weeks, I went back to work at that point. And after 6 weeks, we were able to start to have relations again. I also went back to the gym and worked out with the people I worked out with every 3 times a week, and showered with the guys in the shower, and they have absolutely no idea of anything inside me. Now, one of the things that my wife has said to many women is that had she not known I had the implant, she would not know there was anything inside me that wasn't natural. The implant is totally natural. You look totally natural. You do gain a little girth, but the reality is it is the most natural acting piece of machinery that you can possibly have put inside you that will actually work every single time. The other thing I will just tell you is you can have, it doesn't stop you from having any kind of MRIs, CAT scans, any kind of scans. And the biggest thing is people ask me, well, what about when you go through the airport? Do the bells ring? The answer is absolutely not. So it was basically, like I said, the second best thing I ever did in my life. I'm 75. I hope this one lasts 14 years. If I last 14 years and it fails, I'm going back again for a third one. So I will now turn it back over. And if you have any questions for me or for the doctor, I guess, Mike, it's all yours.
Yep. So first question,